This episode of med-surg Moments was made possible by Hillrom, now a part of Baxter. From next-generation smart beds, care communication apps, diagnostics, nutrition, and beyond, they're uniting to save and sustain more lives worldwide. Visit their website at www.hillrom.com.
This is Alissa.
This is Chelsea.
And this is Caroline. Welcome to med-surg Moments, the AMSN podcast.
This podcast is an engaging look at the lives of and surrounding medical surgical nurses.
We're proud med-surg nurses just like you, sharing our stories, insights, and experiences to support you in your nursing journey.
Patient deterioration surveillance can be a big challenge at the bedside, as it can be difficult to detect. Here with us today to talk about monitoring for patient deterioration and the benefits for all patients is Dr. Jacinda Bunch and Dr. Frank Overdyk.
Dr. Bunch is an assistant professor at the University of Iowa College of Nursing, where she received her PhD in nursing with a focus on healthcare systems, organizational culture, and team dynamics. Her research explores ways in which culture, context, mechanisms, and relationships impact patient safety programs, specifically rapid response systems.
Dr. Overdyk is an engineer and semi-retired professor of anesthesia from Charleston, South Carolina. He is active in patient safety organizations and promoting surveillance monitoring. Dr. Bunch, Dr. Overdyk, welcome to this special episode of med-surg Moments. We're so happy and excited to have you guys.
Good morning. Thank you for having me.
Thank you.
How did you develop such a strong interest in patient deterioration?
My interest in patient deterioration really started when I was a director for a couple of orthopedic nursing units. We've got patients coming back post-anesthesia. We've got patients with a lot of opioids. We have blood loss. We have lots of things going on with these patients. And just realizing how challenging it was for the nurses to really keep close eyes on the patients when you've got so much going on. You've got admissions that are taking an hour to get your patient really in and settled. In the meantime, you have patients in another room, and that's eyes not on them for that hour. And just really that juggle and identifying which patients might most be at risk, which ones are okay for 2 hours to not go in because you're busy with other things. It was just a continual challenge for the staff and for myself when I would go out to work with them and to help, and just trying to figure out ways that we could make that process easier. We also had a lot of standing orders for pain medications. We're post-orthopedic surgery. And our nurses had a list of different choices for pain medications that we could use, and trying to figure out what is the best for that without over-sedation, but keeping them comfortable in this balancing act of taking care of our patients in multiple ways. Their clinical status plus their pain and their comfort, and families upset because people are in pain, and pain is the fifth vital sign. It's really hard to keep all that going consistently. So I think that's where my interest actually first began.
Well, for me, it started about 25 years ago. I was asked by a law firm to review a case of a young woman who had gone to the emergency room because of kidney stones. And as you all know, kidney stones has sort of a difficult pain pattern, crescendo, decrescendo, can be very difficult to treat. And she was quite aggressively dosed with Dilaudid because she was in a lot of pain and sent to the floor. And as her pain subsided, obviously some of this drug was still on board. And there were some fairly new nurses, and she was dosed quite aggressively. She was not on a PCA pump. And she was found in cardiopulmonary arrest at 3:00 in the morning, a mom of 2 small boys, and she did not survive. So I said, this is a horrible case. Lucky we don't have many of these. And the lawyer said to me, Dr. Overdyk, I have a filing cabinet full of these cases, specifically cardiopulmonary arrests on the ward, which is where our more stable patients are supposed to be. And I came across a fair number of patients who were fairly low acuity as well. Young, relatively healthy patients who had come in for an elective procedure or an elective diagnosis and had a catastrophic outcome. So I said, this is something we need to look at, and we've got to do better than that.
Wow, that's a pretty impactful story. But it's interesting that you both have different perspectives, but the focus still being on keeping the patient safe and how to prevent deterioration happening in an area where you just said, Dr. Overdyk, where patients are meant to be stable. What do you think our current approaches are to preventing patient deterioration? We realize we've got a problem, and rather than spend time focusing on that, what do you think we can do to prevent deterioration? My background is obviously predominantly med-surg, and yeah, these patients are exactly like you described, Jacinda. They come back from the OR, the nurse has more patients to take care of. They don't get the time with them that they deserve. What do you think we could do better, perhaps?
Actually, we haven't recognized we have a problem. This is sort of one of these areas that is very difficult and traumatic for med-surg nurses when they have a situation like this, when they have a case like this. It is, in a way, sort of our dirty little secret that we have patients of low acuities and even of higher acuities who have these catastrophic outcomes. And the environment now is actually worse than it was 20 or 30 years ago. Our patients are sicker. Our patients are bigger. They have more undiagnosed conditions like sleep apnea. They're often more drug dependent. So on the med-surg floor, we have more difficult patients, yet our nursing to patient ratios have gone down. We have more patients to take care of. We have a lot of nurses who, especially now with COVID, who are retiring early. We have more inexperienced nurses. We have more traveling nurses. We have more nurse turnover. And nurses have a tremendous amount of administrative work that is being brought upon by the EMRs. In the old days of a nurse being able to really know their patients and spend time with their patients, those are gone. So we need to come up with better systems. Using a monitoring system of every 2 to 4 hours intervals, first of all, that's over 100 years old. And secondly, that time interval was not determined through any best practice or science or outcomes. It was just what we did. And we've clearly now recognized that leaving patients unseen for that long, a lot of things can happen on the ward.
Dr. Overdyk, I definitely appreciate your comments. I love this topic. There's so many things going through my head right now, but you touched on just about everything that I've jotted down in my notes for this topic. And I can say, as a travel nurse, I've been to 2 or 3 different hospitals now, and seeing the advantages that larger hospitals have over smaller hospitals. I think we're all familiar with Epic, which is the electronic medical record system that some hospitals have. Well, the hospital I'm currently at, it's a small hospital, and they don't have all of the upgrades that a larger hospital has. So what happens? I'm not getting told by this version of Epic that, hey, it's time to do your opioid reassessments. Or, hey, it's time to reassess that person's pain. Or, hey, we don't have a news score for this version of Epic. So all of those different things that give me an advantage at one hospital, I'm now disadvantaged because I don't have all of those indicators saying, hey, your patient's in trouble. Or if you don't see your patient, because we're 6 to 7 patients deep some nights. And so when I have that new system, I open up the Epic and I get ding. There's a visual cue saying, hey, your patient could possibly in trouble. And then, it gives you the options of notifying the doctor, reassessing, et cetera. So definitely, I thank you for those comments, Dr. Overdyk.
So Chelsea, you bring up a great point, which is the variability in healthcare and in medicine between hospitals, between wards. When we think about what we call a high reliability organization, like when we get on a plane and the safety of airplanes, it's because every airline and every maintenance crew does things the same way. We have the same equipment, we have the same standards. So you're absolutely correct. It is a little bit of a gamble what hospital you walk into in terms of their safety and quality measures and their culture around that.
I would say, too, another thing that plays into that is really the different cultures and the different patterns and processes that get established within the healthcare settings. We do lots of things, as Dr. Overdyk mentioned, because we've always done them that way. We give medications at 8 o'clock in the morning, which is a horrible time to give medications because you've got physicians rounding and you've got nurses have just gotten on and you haven't even gotten to see all of your patients yet. But yet now you're committed for a 1 to 2 hour block to give medications, and you really need to be doing assessments and other things like that. But we've always done medications at 8 a.m. because it's convenient and it's with breakfast, although breakfast never comes at 8 a.m. So we do things and we get into these habits and we get into, well, we've always done it that way, along with vital signs. We've always done vital signs first thing in the morning, first thing about 4 o'clock, because that's your end of your 8-hour shift. Or if you're only on 12s, then you do it at 8 and 8. And we get into these patterns, and it's really hard to flex out of those patterns and to adjust when things are changing. And when our patient acuities are changing, there's so many different factors that play into that. And for the nurse to be able to step aside and say, no, we need to do this differently, that requires a culture change within the entire unit, within the entire hospital. And as Dr. Overdyk said, then you've got hospitals that are doing it differently. So trying to figure out some type of consistency and really realizing why we're doing things in a certain way. Why do our nursing assistants take our vital signs? Vital signs are very important, and they give you your Muse scores. They give you indications that your patient might be deteriorating. And our nursing assistants are good at doing them because we've trained them to do them. But there's a time lag between the time that the nursing assistant takes those vital signs to the time that they find the nurse to say this is abnormal, or the time that they get them entered into the electronic medical record. And then the medical record processes it with the next calculation and it notifies the nurse. So we have these lags in time when we could be intervening and we could be doing something, but we don't have that. We lose that because we've sectioned things off into silos, and vital signs are nursing assistant roles. The nurse does other things. The nurse is doing the assessment. You could do the vital signs with the assessment. If you don't have something continuous that's in the background monitoring and helping you with that, it's very fragmented, it's very segmented, and it's very siloed in our approach.
I agree, Dr. Bunch. I definitely think your comments bring to my mind the theories of organizational change and what it takes to trigger change, to implement change, and to have sustaining change. So those are all great points. Thank you for your comments.
Well, it sounds like you guys have done a great job at identifying or recognizing what we're currently doing is not working. We're here to talk about a solution.
Yeah, I mean, what can we do to fix this?
We all recognize that the intervals in monitoring are too far apart. There are papers that say that the time between when a patient was last seen by someone and when they arrested was on average even as high as an hour. So we literally can have people decompensate behind a closed door down the hall without being aware that's happening. And the only obvious solution to that is have some kind of continuous monitor on them. It could be a pulse oximeter. With COVID, now everybody knows about pulse oximetry. You can buy one at your local drugstore for $25. And certainly if you stop breathing, at some point your oxygen will go down. If we get to a patient within 5 minutes, everything is just fine. But we cannot resuscitate patients who we see 30, 40 minutes after they've taken their last breath. It's just impossible. And we have thousands of patients who go through this, who experience this, who are found too late. So we need to have some kind of continuous monitor of their status, be it oxygen or ventilation or pulse, anything like that. We've had telemetry units for a long time. They make sense, right? They're created by cardiologists. Cardiologists are fascinated with the EKG. I'm fascinated with people who breathe and who breathe in and out and have a decent oxygen, and they can exchange some carbon dioxide. So there is no reason with the technologies we have now that patients can't be monitored continuously. And in the last 15 years, we've seen institutions adopt it, do the right things, and figure out how to integrate it into the workflow.
I would agree. I think that harnessing technology is one of our next steps in trying to keep patients safe and helping nurses to keep patients safe. Because as a nurse, that's my focus. We're at the bedside. We're the ones who are finding patients who are deteriorating or finding them a couple of hours into deterioration. And that's traumatic for nurses. We have second victims. We have support systems, but we really need to go upstream and prevent the deterioration. If we can prevent the patient from having the deterioration, then we've removed that traumatic experience from the nurse's career. We have so many competing priorities. Reimbursement is being adjusted based on patient satisfaction. Well, patients want private rooms. Patients want their doors closed so that they don't hear the noise in the hallway. Patients want to sleep at night, and we want them to sleep at night, and we want them to rest. And you can't go in every 2 hours waking them up for vital signs and have a happy patient or a rested patient or a patient who's healing well. So harnessing technology where we can have something in the background that is helping to give us the status of our patients, not creating more work, but changing our work so that we are aware of what's going on with our patients and we have that tool that we're able to use to keep our patients safe. Not waking them up continuously, not having to go behind closed doors. COVID has just enhanced that with isolation rooms and people being behind masks and having to full gown PPE to go into a room. We all know you go into those rooms less frequently because we have PPE shortages. Even now that we have plenty of PPE, we're still reusing more than we ever did. So technology exists. It's much less invasive than it used to be. And it can give us the information that we need to take care of our patients.
Yeah, I agree with everything that you just said. And I loved your comment about not creating more work, but changing the way we do work. The hosts here are all from different parts of the country. And certainly where I am, we support continuous monitoring. But then the question comes, when does the patient then change from a medical surgical patient to someone that needs a higher level of care? What are your thoughts on the continuous monitoring becoming routine in a medical surgical environment, given the fact that these patients are sicker than they used to be, they have more than one diagnosis, they've got multiple things going on? How do you think we can incorporate that into a med-surg environment and it becomes second nature? It's not a higher level of care, it becomes the standard of care.
I really do think it is a part of changing the way that we look at nursing and the way that we look at our patients. Rather than a patient that's receiving continuous monitoring in the nurse's brain, that's automatically a higher acuity patient, that's automatically a step-down patient or an ICU patient. And my background is in med-surg. I've been a med-surg nurse my entire career. And to think that I have a patient that's continually monitored, that's a little intimidating at first. However, viewing it as a tool, and that doesn't mean that my patient is going to deteriorate. That doesn't mean that my patient is at a higher risk for deterioration than the patient in the next room. It's a tool that I can use, and it's the way I can change my assessments. It's the way I can change my interaction with the patient. It's the way I can change the interaction with the family, with anyone who happens to be there, with the rest of the healthcare team. I feel that a lot of nurses, it's just a defensive reaction that means my patient's sicker. It means I'm going to have more work to do. I'm going to have to do more monitoring. I'm going to have to do more frequent assessments. I'm not going to have time for everything that I need to do. I'm not going to have time for my other patients. Versus if it becomes the norm or the standard for our patients, and it's just a standard of care, we can change our work patterns and we can change our processes and we can change our interactions with our patients with this new tool. It's just the same as getting electronic blood pressure cuffs. Back when I started in nursing, we just had the manual blood pressure cuffs and you had them on the wall and you stretched them and tried not to go across your patient. It was on the same side that you wanted to use. And when we first got electronic vital sign machines, they were scary. What if they're not right? What if I have to find them? Now I have to clean them every time. I can't find them. No one plugs them in. We changed our work processes. Now you automatically just go plug them in. There's usually one central place that you keep them. We made accommodations to make this work. And we can do that with continuous monitoring as well.
Yeah. So would you think that's one of the biggest challenges to implementing continuous monitoring?
In my opinion, yes. As a med-surg nurse, that's probably what I would say is going to be one of your biggest challenges. If I put on my nursing administration hat, then I'm going to say probably funding. And where do you come up with the money for this? But I also think when you're shifting the nurse's time, you're allowing the nurse additional time to do other things, to do better assessments and to interact with your patients more, to find out more about them and really get to know those patients. So I see it as an investment versus than just a cost.
So both of you have brought up excellent issues to which I think I have some answers. Caroline, you mentioned earlier, and Jacinda as well, the nurses will be intimidated by continuous monitoring. And I've heard it said, we don't want to turn the wards into ICUs because in ICUs, we hear all the alarms going off all the time. So there are a number of things that the early adopters who successfully do continuous monitoring have achieved. One, they have the nurses on their floor say, do not take this continuous monitor away from me because I have such a great level of comfort now. That was in the past. I never want to go away from that. That's proof of the pudding. So you say, well, aren't you called to see the patient a lot more to respond to alarms? No, we actually have a triage system where when the alarm first goes off, we have someone else who just goes to check on the patient if they're talking or if they got out of bed or something like that. They've implemented workflow changes whereby continuous monitoring does not become intimidating or is a burden, but really becomes a comfortable blanket, becomes a security, becomes something that ensures that you will not walk into your patient's room and you find them in cardiopulmonary arrest. So there's a tremendous amount of comfort to that. To Jacinda's point, as a C-suite person, cost, those issues have been solved. Absolutely, there are cost pressures. But think about what we charge for a hospital room at night. And think about the fact we have a responsibility to our patients not to have catastrophic preventable harm, certainly on our ward patients. So I think we can create an environment, and we're going to go through some more of these implementation issues, how to do this successfully. And then I think we're going to have a much happier nursing and patient group. Now, technology can become burdensome if you don't do it right. But we are not talking about ICU patients with central lines and things like that. There's just a few things we need to know about these folks. You all know that patients who end up in the ICU from the ward have the worst outcomes, worse than any patient who is admitted to the ICU from the street or from the OR. And that's because these patients have deteriorated under our watch, and we don't know what's going on. The value of continuous monitoring is that we can spot patterns and trends. And I've continuously monitored thousands of patients over the last 20 years. And I can tell you, invariably, there's a pattern and trend that goes along with every decompensation. And we knew about this. And the literature is full of papers. When we go back and retrospectively do a root cause on an arrest, we go, oh, look, we missed that. Let's use technology to help us bring in those warnings in a timely fashion.
There's been many patients that we've had post joint replacement. And to get a joint replacement, you have to go through a medical clearance. You're deemed healthy. So these are patients that should be very low risk, very stable on the unit. And there's been multiple patients that I've taken care of and had my nurses take care of that we put them on telemetry for the first 24 hours post-op, just as a precaution. And we've picked up arrhythmias that you never would have known about. They've been medically cleared, safe for surgery. They're completely healthy, but yet we find an arrhythmia, we find something going on post-operative when we have that monitor on. And then taking that monitor off was kind of a little scary because we only have 24-hour monitoring and it's not a life-threatening arrhythmia, but can't we leave that on a little longer? So if we have non-invasive monitoring, a sensor in a bed, the patch that Dr. Overdyk mentioned, if we have that, there's no reason to really graduate them until they're ready to go home. Just think about the post-surgical patient. We tend to leave that IV in until they're ready to walk out the door, because guess what? As soon as you take that IV out, you're going to need something. They're going to fall. They're going to have horrible pain. They're going to become nauseated, and you need that IV access. So we leave that in until the last moment. No, we're not using it. It's on a saline lock, so they're not tied to wires. But we have that in place as a precaution and as a safety convenience for the nurse and for the patient. Same thing with a non-invasive monitoring system. I would envision these stay in place, intact, connected, wirelessly, non-invasively, until that patient's ready to walk out of the door and go home.
Yeah, I couldn't agree more with what you're saying. And certainly the takeaways from my perspective here are technology is definitely here to stay. We also have a tremendous amount of new nurses who are also chronologically younger nurses, and they didn't know what a phone with a cord is. They live in a whole different world. And so I think it's going to become, or I would hope to think it will become the norm as we move forward. When you go on an airplane, it doesn't matter which airline you're with, everybody tells you how to put that seatbelt on and your chair upright and the oxygen will fall. And it's consistency. And I think that's one of the things we have to perhaps look at. And everyone that's listening, I encourage you to have dialogue with your leaders about continuous monitoring and how it can actually make your life easier rather than more difficult, because there's enough challenges out there as it is. So just my 2 cents, my takeaways from everything.
I completely agree. Now, and I'm wondering if maybe the shift isn't looking at it as a continuous monitor, but a tool, like you were saying, like that saline lock, because when we look at it as continuous monitoring, there is that fear that I have to see what's going on with my patient. And if I take this away, then I'm going to miss out on some information. And so looking at it as that additional resource, just having that insight. I also have an ortho background, and I think about all of those super healthy ortho patients that like to throw PEs 5 minutes before you're trying to discharge them. And I'm like, this would have been a dream, because instead trying to diagnose a PE with a pulse ox, I've got to strengthen that skill, but also something like this would have been so much more helpful. So I definitely think that there is a need for this type of assistive technology for nurses. Dr. Bunch, Dr. Overdyk, it's truly been a pleasure having you on this important episode of med-surg Moments. So thank you so much for sharing your time and expertise with us.
You're welcome. I enjoyed it. Thank you.
We do look forward to connecting with you on our next episode of med-surg Moments, the AMSN podcast. In the meantime, we want to hear from you. Send us your questions, topic ideas, and feedback via our official med-surg Moments email address. That's amsnpod@amsn.org. That's amsnpod@amsn.org.
We'd also like to remind you to become a member of the Academy of Medical Surgical Nurses or review your membership at www.amsn.org. You receive lots of cool benefits and perks, such as discounted pricing on the annual convention and continuing education.
We encourage you to help us spread the word and subscribe to the med-surg Moments podcast via your smartphone podcast app to receive notifications of future episodes. Please be sure to leave us a review and recommend med-surg Moments wherever you get your podcasts to help us reach even more listeners.
We invite you to join the conversation by sharing your ideas and questions on AMSN's Facebook, Instagram, LinkedIn, or Twitter pages, and don't forget to add #MedSurgMoments to your post. Simply enter AMSN on the search field of any of these social media platforms to connect with us.
The content within the med-surg Moments podcast represent the views, thoughts, and opinions of the co-hosts and may not necessarily reflect the views, thoughts, and opinions of the Academy of Medical Surgical Nurses. Until next time, I'm Alissa.
I'm Chelsea, and always remember, med-surg Moments is a moment in our lives, a moment in our med-surg careers that makes a huge difference.